Okay, good morning and good afternoon. Thank you for joining us today. This will be an exciting webinar. My name is Arindata and I'm from the Health Policy Plus project where I'm the Technical Director for Health Financing. Just a few quick house rules before we get started for today. You will find a chat window in the corner of your screen if you are doing full screen. And during the presentation, as well as at the end, where we will have an explicit Q&A section, please do go ahead and type your questions in, and we will take them up with the panelists. Hopefully everyone can hear me quite well, and I will go ahead and introduce our topic as well as the panelists for today. So why do we need to speak to the need for a trend shift in domestic funding for family planning? We will hear today about the Family Planning 2020 or FP 2020 partnership and the 69 low and lower middle income countries that are its focus. Looking at these 69 countries and the goals that were set when the Family Planning 2020 came into being, the intention to raise total users of modern family planning in the developing world are very ambitious. The majority of family planning programs in these focus countries are quite dependent on external resources. So overall, bilateral donors have actually contributed $1.5 billion for family planning in 2018. And these funds mostly target procuring large quantities of contraceptive supplies for entirely free or highly subsidized provision. But they also support many critical program activities that raise demand, support counseling and client education, and fund supply chains and logistical systems. Country governments have increased their contribution to their programs and have long supported the health worker labor and facility overhead that keeps family planning interventions going at scale. But will such broad health system investments be enough? Recognize that with COVID-19, not only have family planning services been disrupted and country finances and fiscal conditions worsened, but there is more work to be done than ever before. In the future, we will hit a plateau in external financing for family planning commodity supplies, even as demand continues to rise in priority countries. With such a plateau, there will be some middle-income countries that should transition from externally financed, fully free commodities. In response, hybrid approaches with partially subsidized commodity supplies and more private market provision will work to satisfy demand in some markets. But we must ensure that the poorest women, especially in regions with high baseline fertility and continuing unmet need for modern contraception, can still be fully served by government systems. So it seems inevitable that country governments will need to step up in a much bigger way. In today's webinar, we will talk about how external funders can view their contributions a bit differently than filling a critical gap. That is, while funding a share of the cost of country programs, they can also intentionally make an effort to increase the sustainability of these programs. In this paradigm, external funding will see each country's family planning market in context, and using an evidence-based approach, stimulate domestic government funding as a contribution towards the cost of services for the poor and vulnerable, as well as private market supply for those who can and want to receive their products from commercial sources. In this future, through technical assistance and advocacy, family planning will be included in financing schemes such as social health insurance that pool funds and pay providers for services for their members. All of these and more possibilities exist to put domestic financing for family planning on a growth path, tailoring the solutions to each country. So, how does an external funder working with its partners stimulate such a domestic response? To answer this and other questions, we have assembled a panel today that features our project, Health Policy Plus, as well as some key actors who work in financing for vertical programs, including family planning. We will hear from the HIV world, where similar initiatives have been in motion. But first, we will hear from Martin Smith, who is the Managing Director of the FP 2020 Partnership. Next, my colleague Elise Lang from HP Plus will introduce the framework we have been using to work with family planning programs and stimulate such a catalytic response for domestic financing. We will then hear about the experiences from the USAID-led Sustainable Financing Initiative for HIV from Susanna Baker, who is the Branch Chief, Health, Finance, and Economics at the Office of HIV/AIDS at USAID. Finally, we will hear about how catalytic approaches are already being tried in family planning programs and what success have we had with that, This will be from Kojo Loco, the Executive Director of the Challenge Initiative. So first, to introduce the need for financing and the topic in more detail, I turn over to Martin Smith. Martin?
Thank you very much indeed, Arun. Good morning, good afternoon, good evening. Great to have so many participants with us. And as Arun has said, I'm going to set out the financial context in discussing this urgent need for catalytic investments to incentivize domestic resource mobilization for family planning. And it's critical that our partnership, including donors and implementing partners and others, are prepared to support countries in these catalytic efforts in line with those countries' broader health and development goals. And the urgency of this work is very clear to us, I think. Domestic resource mobilization for family planning, while encouraging, certainly not going fast enough in many FP 2020 countries. It's urgent work due to the long-term trends that we're seeing in donor funding. I'll go through those in just a couple of minutes' time. It's urgent because we're seeing some diversion of these scarce resources to address the current COVID-19 pandemic. And also it's urgent because of the scale of our ambition for 2030, our goals of universal access in the next phase of the family planning partnership mean that we need significant emphasis in this area. We'll go to the next slide. So this slide will be very familiar to many of you who read our annual progress reports. You'll see since 2012, 53 million additional women and adolescent girls using a modern method of contraception across the 69 countries, above the historic trend, yet not on track. And all roads towards universal access in 2030 do lead through an additional 120 million. And this really does spur the need for urgent action on financing for family planning generally, and specifically on this catalytic investment piece that we're talking about today. The impact of COVID-19 is also very important to consider in this context, of course. The Guttmacher study just a few months ago looked at the LMIC countries and saw a potential reduction of 49 million women that would have an unmet need for family planning if service delivery were to drop by 10%. We also understand, of course, the impact of the pandemic in terms of shrinking the available fiscal space for countries. The next slide, please. Again, a familiar slide to many of you. This is from our progress report of November 2019. It does show the total expenditure on family planning across the 69 countries in the fiscal year of 2017. And you'll see some encouraging percentages here, particularly around domestic governments, 32% of the total expenditure coming from those domestic governments, 4% there of other coming from other domestic sources, but still highly donor dependent in many ways. And I'll show that 32% of domestic government expenditure and how that is currently skewed in a certain set of countries that are generally the lower middle income countries rather than the lower income countries in just one moment. One further point here, if we look at the total modern method users represented here, just around 314 million modern method users, and this expenditure of about 3.8 billion, it's about $12 per modern method user. If we were to look at what we would need to do for the 120 million additional users, that would require probably around $4.5 billion of expenditure per year, as opposed to the $3.8 billion you see here. So the scale of the challenge is clear. We'll move quickly to the next slide. In looking at that, what the financial amount that is required, let's look at a wider set of countries for a second and draw from this excellent Guttmacher adding it up 2019 analysis that was published just a couple of months ago. So if the 218 million women with an unmet need for modern contraceptives were to use the same mix of methods as our current set of users of modern methods, then direct program and system costs would need to increase to $12.6 billion annually, up from the current $7.1 billion, which is spent at the present time. I'll move on again to the next slide and let's speak a little bit about that element of domestic expenditures that I mentioned earlier on. So FP 2020 and all of the commitment-making countries, our partners at Track 20, we are tracking domestic government expenditures on family planning as the 12th of our 18 core indicators. And we collected this data for 37 countries for the fiscal year 2016-2017 in our last annual report. But you'll see a very clear picture here in that the majority of that domestic financing for family planning of those 37 countries, 92%, came from lower middle income countries, and only 8% of that financing came from low income countries. We had at one end of the scale, if you like, over $300 million spent in this fiscal year in India, $20,000 spent in Mali. Much different countries in terms of their size, of course, but the scale of the challenge here, again, I think is clearly articulated. We're currently collating the expenditures for the fiscal year 17-18. We'll publish them in just a few months, but we've already heard from 14 of our 47 commitment-making countries that they may need to shift or reallocate their committed family planning funds as a result of the COVID-19 pandemic, which may include newly established family planning budget lines. So again, some headwinds that we're seeing there in terms of domestic expenditures. I'll move through slides, the next three slides pretty swiftly. This just shows again the diversity of country context that Arun was referring to in his introduction. So here we show for Bangladesh, 72% of their 2016 family planning expenditures coming from domestic sources. On the next slide, we'll see in the Kenya context around 25% of family planning financing coming from domestic sources. Obviously, that number has shifted in the few years after devolution of budgets to the county level in Kenya. And then I'll move on to the next slide and show you Senegal, where we can see around 28% and an increasing amount of domestic government expenditure on family planning, but still highly donor dependent in the Senegal context at this time. So I'll move on to the next slide. And each year we ask the commitment-making countries to FP 2020 to report on how they are doing in relation to their several FP 2020 goals. And 44 countries have made a financial commitment as part of their FP 2020 goals. And you can see here of the 40 countries that reported in July of 2019, around half of those countries are off track, and they self-assess themselves as off track. We then analyze and concur and verify that statement. And just a few examples here. Tanzania deemed themselves to be off track. They set an ambitious commitment of increasing allocation from 14 billion to 17 billion Tanzanian shillings by 2020. That's from about 6 to about 7.5 million US dollars. Zimbabwe committed to innovative financing approaches to mobilize domestic resources for contraceptives. They deem themselves to be off track at this point in time. DRC pledged to allocate each year a budget line for the purchase of contraceptives from domestic sources of at least $2.5 million. DRC deem themselves to be off track to reach that financing commitment at this stage. We'll move to one of my very last slides. So here again, just to contextualize that $1.5 billion of bilateral donor funding, again, that Arun referred to. So that is the high point when we look at the years since the inception of FP 2020 in 2012. But the indications are that we will not see very significant increases. There are some smaller increases coming from the additional pledges made in 2017, but we will need to rely for these significant increases on domestic sources as we look ahead to the decade in front of us. My penultimate slide, very quickly, on the next slide, shows that within the family planning vision framework to 2030, increased, diversify, and efficiently use of financing is front and center, is one of 5 key focus areas that we will be working on with you all as the broader the broader family planning stakeholders and community. And here on the last slide, we see that there will be a critical 2021 commitment-making process, and we're very excited to work with the community and really see great value in focusing in on these catalytic approaches to domestic financing with all of you as we work with countries and partners for commitments to the next family planning partnership. And with that, very excited to hear your questions later on, very excited to hear the rest of the panelists. It's my pleasure to hand over to our colleague, Elise Lang from HP Plus for the next section. Thank you, Elise.
Thanks so much, Martin. Hello, everyone. My name is Elise Lang. I'm a technical advisor at Palladium working on the Health Policy Plus project. As Martin clearly demonstrated in his presentation, investments are needed to increase domestic resources for family planning. However, now how do we then identify what actions are most appropriate in each different country context to stimulate this domestic resource mobilization? I'm going to be talking about a framework we developed that provides structure for stakeholders to identify opportunities for catalyzing investment. Next slide. Before talking about the framework, let's just review the 4 family planning program areas. Demand generation refers to increasing clients' desire to use family planning by changing their attitudes or perceptions about family planning or increasing their awareness or knowledge about family planning methods. Service delivery refers to the provision of family planning services, information, and methods. Supply chain refers to the storage and distribution of family planning commodities. And family planning commodities refers to the procurement of contraceptives and commodities. Next slide. Each family planning program area faces unique financing barriers. We can break down these barriers into 3 different categories. Cultural and social barriers are beliefs or customs in a country that reduce demand and provision by qualified providers. This could include, for example, religious beliefs or pronatalist beliefs or beliefs that women do not have the same rights as men. Other barriers could be socioeconomic and technocratic, which provides a bureaucratic perception that the population needs to grow or that there's no need to limit population growth. So this could include, for example, the belief that high labor mobility makes it difficult for women to consistently access family planning. And then lastly, health system financing and functioning barriers are related to underdeveloped and under-resourced systems that restrain service provision, like human resources for health. Next slide. So to take the supply chain as an example, in a country where there may be limited to no public resources or insignificant qualified human resources for health, one potential action to be able to better support the supply chain would be to analyze the current government budget to determine what resources are available, could be mobilized, or could be used more effectively. This evidence base could then form the foundation for advocacy to government leadership for funding and/or policy development, which would hold the government accountable for providing funding for family planning supply and distribution. Next slide. After a review of relevant literature and countries' experiences, we've identified 4 main types of responses to these financing barriers: advocacy, capacity development, drafting, revising, or implementing laws, regulations, and policies, and reducing the risk of investing in the family planning market. So the type and mix of responses that are appropriate in any given country context will depend on the country context. However, evidence generation is a key cross-cutting theme. Next slide. So these responses or actions are effectively catalytic investments. We've defined catalytic investments as activities, programs, or mechanisms which leverage existing political, social, and financial opportunities to increase the likelihood that decision makers will raise allocation of domestic resources or improve the execution of them. Next slide. So now that we've defined what a catalytic investment is, how do we now determine what kind of catalytic investment is appropriate and responsive to a particular country context? To help with this prioritization, we developed a framework based on archetypes from crossing two different dimensions: a country's recent growth in modern contraceptive prevalence rate, or MCPR, along the S curve, and a country's health financing system's maturity. Next slide. So to start with the S curve, as we've already seen, there are barriers to funding each aspect of the family planning program. Each family planning program component needs to be prioritized at different points during the contraceptive prevalence rate growth in a country. So when MCPR is low, investment is particularly needed in demand generation, shifting social norms, and establishing infrastructure to deliver these family planning services. Next slide. As MCPR increases, the investment is more needed to reduce barriers to access, ensuring contraceptive availability and high quality services, and in sustaining demand generation. Next slide. Then as MCPR starts to level off and reach its maximum, investment is needed to ensure MCPR equity and long-term sustainability. Next slide. The maturity of a country's health financing system is also important for informing what catalytic investment is most appropriate and can have the highest impact on financing family planning. So health financing maturity is based on fiscal space for health, dependency on external financing, and the level of health insurance coverage. The financing environment relative to family planning can be categorized into 5 main characteristics. Each of these are conducive to different domestic resource mobilization mechanisms and investments. So country context can often include more than one of these characteristics and will rely on a combination of them with strong political will and strong support from a broad range of stakeholders in order to be successful. Next slide. So I'm not going to talk through each one of these, but just to provide an example, a country has an existing health insurance scheme and can be considered to have an emerging health financing maturity level. So one potential opportunity for domestic resource mobilization would be to integrate family planning into the benefit package of that insurance scheme. However, there might be several challenges to doing this, such as a restricting law or regulation, or even a lack of information or data to explain the financial implications of including family planning in the benefit package. So one potential response and catalytic investment to that could be to conduct a financial analysis and advocacy to support a policy for inclusion of family planning in the benefit package. And then this successfully including it in the benefit package would then help provide more sustainable financing for family planning services and commodities. Next slide. So here I just want to show you the 2 dimensions together, the S curve and health financing maturity. This is an example from Kenya. In Nakuru County, HP Plus supported the reproductive health coordinator to develop materials and sensitize the county health management team to the importance of family planning and the existing needs within the country. While MCPR is relatively high, there was a low local government commitment to family planning, and there was a need for funding to ensure a wide range of methods were available and the supply chain was adequately supported. So working with the county assembly and civil society organizations, the county successfully advocated for more than a $40,000 increase in their domestic budget allocation for family planning. And also they were able to create a specific sub-program for reproductive health within its budget. Catalytic investments in advocacy, capacity development, and policy have been able to lead to more sustainable financing for family planning in this context. So I hope this helped explain the framework and how it could be used and how it can be helpful in prioritizing investments. So I just want to take a small brief minute to talk about the process for doing this. Next slide. So first, a multi-sectoral group of stakeholders, either an existing technical working group or a new one, should get together and conduct a landscape analysis and conduct key informant interviews to be able to better understand the barriers and enablers to investing in and mobilizing domestic resources. The stakeholders should then identify the country's S-curve and health financing maturity categorization, which can be done using USAID's Family Planning Financing Roadmap. The stakeholders should then evaluate the opportunities and develop a roadmap to execute it. We actually conducted this process in Senegal and identified investments that would be most appropriate given the context. And if you're interested, a short brief on this is posted on our website. Next slide. So you can find out more information about the framework and how it can be used in the guide and summary brief posted on our website. The guide provides a comprehensive breakdown and explanation of the framework, including examples and of context-specific investments. And the summary brief is more of a short explanation of the dimensions of the framework. Next slide. So this concludes my presentation. We will now have the pleasure of hearing from Susanna from USAID and Kojo from the Challenge Initiative, who will be providing us with examples of Catalytic investments for mobilizing domestic resources and the lessons learned in the process. Susanna, over to you.
Great, thank you, Elise. And thank you for the opportunity to speak about the Sustainable Financing Initiative for HIV/AIDS, which will be speaking to the catalytic impacts we had in the HIV space. Next slide, please. So to give a little bit of background, this was really set the context for what we were trying to achieve with the Sustainable Financing Initiative. On the left-hand side, you'll see what the overall health financing landscape looks like, and it's very similar to what Martin presented for family planning. You'll see a large out-of-pocket, the orange is the out-of-pocket, you'll see a large contribution from out-of-pocket. The blue is the domestic resources, the host government provides those resources. The green is the donor funding, and then the purple is the private sector. So you'll see on the left-hand side, the overall health, it's really financed by out-of-pocket with an increasing share of domestic resources. If you move to the right-hand side in the HIV space, you'll see the grand majority comes from donor resources, which is what we know in the HIV space. And so this initiative really intended to grow the host government resources, the donor government, and then increase the purple as well, which is the private sector, while keeping the out-of-pocket spending as low as possible. Next slide, please. So SFI, the Sustainable Financing Initiative, what was it? It was a $48 million investment in 18 countries in the Asia Regional Program over 5 years. We're in the last year of implementation. And we really focused on measurable results, targeted investments, and leveraging efficiency gains to increase the resource envelope and enhance domestic resources available for HIV/AIDS. We bucketed our interventions into 3 technical areas: public financial management, social health insurance, and private sector engagement. And you'll see on the right-hand side which countries we did which interventions in. But I will now speak about 2 specific examples in the social health insurance space and the private sector space. Next slide, please. So the first example I want to speak to is the social health insurance program in Vietnam. We achieved an overall return on investment of 125% across all the different interventions we did, which I'll go into further depth on the next slide on. But some of our high-level results were 90% of PLHIV are now enrolled in the social health insurance program, and that increased from 36% when we began our 3-year intervention in Vietnam. Almost 100% of the outpatient treatment facilities have been integrated into the public health system, and the domestic funding for HIV has grown from less than 1/3 of the program cost to over half of the program cost. And I think most tellingly, and speaking to the sustainability, is that all of these interventions have continued to increase, or all these impacts have sustained and have continued after the SFI funding ended. Next slide, please. So these were just the 3 areas that or some of our activities that we actually did in Vietnam to get an idea of what the individual return on investment was and what the actual activity was. So the first one was was policy change to help revise the social health insurance law to include select preventative services. And the ROI on this one is currently 0 because the policy change is still pending. So that will clearly change if that policy, if and when hopefully that policy does change. The other 2 were TA, and the first one was, technical assistance to the Ministry of Health, and then the Vietnam Social Security through the social health integration process. And for that one, which was really integrating the outpatient clinics into the social health insurance scheme. We had a slightly positive return on investment of $1.18 for every dollar that was inputted into this activity. And then the final action was TA to help design and monitor policies and technical guidance for antiretroviral payment and reimbursement. And this one had a very high return on investment of $4.67 for every dollar that we spent. So that's just to give you an idea of how we calculated the return on investment, and that there can be quite a difference of return on investment in one activity. Okay, next slide, please. I will now move to our private sector work with the example in Tanzania. There we achieved a return on investment of 1,468%, which is quite telling. It was a small investment that we did. And what we did, we leveraged $6 million in private capital through Development Credit Authority funds. And for those who are not familiar with the Development Credit Authority funds, it is partial credit guarantees, which mobilizes local financing in developing countries. And the guarantee agreements encourage private lenders to extend financing to small and medium scale borrowers who lack access to credit facilities. And so in this activity, there were 53 loans dispersed, including over 30 for HIV-specific service providers. And we saw the impact on HIV results by increased HIV testing of about 35% at facilities that received this financing. So it was a pretty impactful activity. Next slide, please. And what we actually did for this activity is provided technical assistance to the financial institutions, which were the banks that were providing the loans to the small and medium enterprises. And then we provided support to the health facilities to help them apply for those loans. And on the right-hand side, you'll see just a little snippet of one facility and what that loan managed to help them do. Which was an increase in patient volume of 16% over a 6-month period. So we saw the impacts on the HIV response. Next slide, please. I'll just now briefly touch on some of the lessons learned that could be applicable for the family planning space. So while we did measure ROI where it made sense, the return on investment, I think it's important to note that it shouldn't be the only measurement. And in some cases, even though we had maybe a 0% return on investment, that didn't necessarily mean that important work wasn't done. For example, the policy change in Vietnam is still pending, and that could go through, and that would be a very impactful activity. Also, although we had to focus on HIV, in many cases, our activities had a spillover effect into other parts of the health system. We worked in Kenya at the county level on the budgeting process, which clearly impacted other health areas, not just HIV. What we found to be the most crucial key to success was the enabling policy environment, and we really, the government in which we were working really needed to have some political will to want to do these types of interventions for them to succeed. And then in terms of lasting impact, as I said in the Vietnam case, we really hope that beyond just the period of implementation, we wanted to hopefully see these gains sustained. And so things like structural change that, continue past the post SFI period were really important for us to focus on. And we have seen, just on a personal donor level, a lot of the sustainable financing activities which were funded centrally have now transitioned to the USAID mission budgets, and they have chosen to finance a lot of the sustainable financing activities through their own budgets. So that is my presentation. Thank you. And I'm going to turn it over to Kojo now.
Thanks, Suzanne, and hello, everybody. So I will be sharing some experiences of the Challenge Initiative. And it's worth noting that unlike others that operate at the national level, TCI operates at the sub-national level. Next slide, please. So the Challenge Initiative is a platform that enables local governments to scale up high-impact family planning approaches for the urban poor. And it represents a highly innovative approach to development aid intended to strengthen the understanding of scale, impact, efficiency, and sustainability. It is currently, we are in 94 cities in 10 countries in Africa and Asia. Next slide. The 4 stages of our engagement are stage 1, the expression of interest, Then we move on to program design, implementation, and then graduation of the cities. It's important to note that TCI, we do not implement. It's the local government that implements. We provide coaching and support for the local government to implement. At the expression of interest stage, that is when the cities come in. We don't impose on the cities self-select to join this program. And there's an eligibility criteria for the local governments to join this. And the three important ones that I like to share here is we assess them for their political commitment or political leadership. We look at their resource contribution that they're putting on the table, and then systems readiness. Systems readiness in that we do not go to locations with the worst health indicators. We go to locations or cities that are ready to fly, that they have the right political leadership, have the systems that can help create a change. Most importantly, they need to put money on the table. So after that stage, they go through the other stages, and we engage the cities roughly about a 3-year period until they get into graduation. I'm glad to say that we just entered a stage where a few cities have now graduated. Next slide, please. I just wanted to also point out that we are seeing some good results. We've seen over the past years, client volume increase in these cities. In the past year, we saw close to a 50% increase in client volume. And also we are recording an annual MCPR growth of about 2.5% across the cities. And since the inception and as up to June 2020, we have had about 1.2 million additional users. Next slide, please. Local governments make promises, and are they keeping the promises? We're seeing very impressive commitments and keeping their promises in this area. Over the past 3 years, again, we've seen increased commitment. But note that they're not just committing, they're actually releasing and spending the money. And in the past year, we've recorded an 81% increase in monies released and spent. Next slide, please. I'd like to focus on one country, Kenya, and then move down to look at Kilifi County, a county which has a dynamic governor that is committed to family planning. And you see that over the past 3 years, Kilifi County has continuously spent out their money. Also notes that they're not just committing their money and spending, but is also resulting in some good impact. And on the right, you see that we have an increased client volume of 63% in Kilifi County in the past year. And we asked our folks on the ground that what is creating this, and those points out there: advocacy, engagement with technical and non-technical leaders of the country, the program implementation team built within the health system, and also bringing in other akin ministries such as gender and social services. Next slide, please. So I'd like to highlight common strategies for success across cities. And I put them into 3 buckets: advocacy, engagement, coordination, and management. And advocacy, yes, advocacy, advocacy, advocacy. But I pulled out 3 points. It's important that we advocate for dedicated family plan line items. And that's what we're seeing or doing in our cities. We ring-fence the family planning money and dissociate it from RMNCH. Also, it's important to align communication and advocacy efforts with local priorities. And also bring in, advocate to non-technical teams such as finance and admin. Also, we coach internal people to do the advocacy, such as in advocacy core groups as we have in Nigeria. And so the advocacy is done internally to ensure that the monies are released and spent. And the engagement, the government sits in the driver's seat and they lead and implement. Also, the incentive of the challenge fund that we put across goes a long way to help them with the release of the funds. Then we instill sustainability from day one. We also build into the subnational plans as the costed implementation plans. And the streamlined cost-effective interventions that are introduced to the cities, make it easier for the local governments to see that their money is going into activities that is generating results. And we work with the 20/80 rule, the Pareto principle, where 20% of our activities account for 80% of the results. Data for decision making is critical. Under coordination and management, we coach to strengthen the financial management capacity of the local governments. We also track release and expenditure on a monthly basis, working with the program implementation teams built within the health system. And then we build the capacity of the local government to do partner coordination, helping them identify the gaps and filling in the gaps when needed. Then regular meetings with the political leadership alongside the health management team is critical, reviewing data and impact at the highest level. Next slide, please. So some challenges that we have. FP is often not a high priority for many local governments. There's a general shortfall in government health budgets. Resources committed are not always released and spent. And then verifying and tracking expenditures is a challenge, but we are improving upon it. Also, sometimes changing political leadership after working with a particular leader for a while, then they changed. And then the alignment of the financial calendars also is a major challenge. And then of course, the emerging disease outbreaks such as COVID. Next slide, please. There are a few ideas for in the immediate future that we're considering. We're looking at a calculator for local government's contribution per capita. And some of the variables we're looking at is estimated GDP, MCPR, and population. We're also coaching the local governments to improve their public-private partnership to leverage more of the private sector operations and resources. We are looking also at supporting the community to demand accountability from their leaders and generally look at ways by which we can bring community resources in there. Finally, we are also experimenting some kind of accreditation for the cities and wanting to brand them as investment-ready cities with high return on investment. And we believe that if we set this up, local governments will contribute or work towards making their cities investment-ready cities. And through that, they will be more diligent in putting more resources into family planning. So I think these are just some ideas that I wanted to share there. I'll be looking forward to some questions. Thank you.
Many thanks, Kojo. And I think this has been really instructive in terms of seeing the parallels between PEPFAR's initiative and yours, and also harking back to what Martin and Lise have said. So that's the end of our presentation section, and I've noticed that we have quite a few good questions that have come in through the chat box. I'm going to start directing them to our panelists. So let's take them off the top. So Martin, right at the beginning, there was a question for you, and maybe you can speak to a point you highlighted in your presentation, that there were quite a few stark differences across the countries, not just because they're low-income countries or lower middle income, but also in terms of the share of their total family planning program needs that were being financed from domestic sources. What do you think has driven this kind of difference, this diversity in response from governments in your tracking of commitments and your experience over the last few years of the Family Planning 2020 initiative? Over.
Thanks very much, Aaron. Thanks for the question. So yeah, the breakdown LMIC, LIC is really just a summary. 37 countries with very significant differences that you can see on our website. So I'd like to say that, you know, a lot of that lower middle income country amount is driven by 7 big countries, by India, Indonesia, Bangladesh, Pakistan, Egypt, the Philippines, and Kenya, which are really providing very significant amounts of domestic resources into their family planning programs. As we heard from Elise, of course, the fiscal space that's available to countries, lower middle income countries compared to low income countries, very, very different. The health financing maturity in terms of insurance schemes, prepaid schemes, and so forth. Perhaps a way of looking at this is to look at per capita spending at some point. Certainly, lots of the lower income countries that made FP 2020 commitments started relatively conservatively in their financing commitments, establishing family planning budget lines, making sure that amounts were allocated and then expended over time. But as I mentioned at the end of my presentation, we have an opportunity now, of course, in the context of COVID-19, to work with countries to set better, ambitious yet realistic financing goals, not just around perhaps contributions from domestic resources to commodities, but broader contributions to family planning, not just in low and middle income countries, but in low income countries as well. And we will be working with all of you over the next few months as we set that up with these countries. Back to you, Irene.
Thank you so much, Martin. So if I may direct the next question to Elise, just taking the questions in order of speakers. So there's a question about family planning commodities, which, as I think all the speakers have mentioned, is heavily financed by development partners. So this question comes up quite often in our country work, as you know. If commodities are free and are currently financed adequately, is there any real rationale for integrating these services into insurance, especially social health insurance? Over to you, Elise.
Thanks, Ryan. Yes, definitely. And actually, this is something that we talked about at the most recent family planning, the FP 2020 focal point meeting in Senegal. It is important for a country to consider including family planning into the benefits package, because as demand is continuing to increase, and as we've seen from Martin's presentation, donor and partner contributions to family planning is stagnating. And as countries are increasing their economic growth, it makes sense for them to slowly start to take on the cost of these commodities. Obviously, it's going to take time for an insurance scheme to be able to pay for these commodities, but as we've seen in other examples, for example, in Vietnam, it is standard practice and possible for insurance to be able to pay for methods and commodities.
Great, thanks. Thanks for keeping your answer clear and succinct. There's a quick follow-up for you before I turn to the other speakers. Can you also speak to how we can raise domestic finance with things like what you mentioned as one of the program areas, demand generation? Oh.
Sure. So demand generation is often funded by the government, but also very much funded by external funding. And so sometimes the potential barriers to domestically funding demand generation are cultural and social, or perhaps there's a cultural understanding that there's a socioeconomic understanding there's still a need for workers, or there's religious beliefs or pro-natalist beliefs, for example. So some of the potential catalytic investments to overcome those would include things like engaging community and religious leaders, or engaging in advocacy, and then hoping that will then push for a policy change to be able to fund demand generation. But also, there is a way for demand generation to be integrated across health areas, such as, RMNCH and nutrition. And so this is also a great opportunity for co-funding from subnational governments. So it should be something that can be included in subnational government planning and budgeting. And determining, also developing some tools to estimating what those needs would be for demand generation.
Thanks, Elise. Yeah, some work HP Plus is doing in Indonesia speaks to that. So if I may turn to Susanna, there are a few questions to follow up on what you spoke to in terms of the Vietnam case. So if I understand this question correctly, the intention is to understand whether, as funding is directed through social health insurance for some of these vertical programs, would that sort of reduce incentives for the government to finance the same programs through their budget line items? And would that lead to an overall reduction in financing available from domestic sources? Or what is the complementarity in your view between these funding sources? Over.
Yeah, that's a great question. And I think it's one that we were very cognizant of when we were undertaking the initiative. This idea of, does DRM for one specific disease pull DRM away from other diseases? And in terms of the funding sources. So it is something we definitely thought about in the and the way I see it as, I think integrating HIV, as probably most people on the call know, HIV tends to be a very verticalized program in many countries. It's, receives massive investment by the US government and other donors, and it tends to be a standalone program in many instances, which really tends to be an inefficient system if we're moving towards the majority of the response being funded by the host government. And so for me, it makes the most sense in an efficiency standpoint to have all of the diseases, and especially HIV, integrated into a national health insurance program to the extent we can do that, rather than having the government continue to fund it as a standalone program. And so we didn't see any impact in Vietnam, although I don't know if we specifically examined this to the extent that you might need to get the full answer. But our thinking was the integration of diseases into one national platform would, in the long run, be more effective and efficient for the host government in taking over these types of vertical programs.
Thanks, Susanna. So there were a few questions for Kojo, and Kojo, I'm going to try and bunch them together so you can answer them in sequence. So first, I think there's a question about how you worked at the subnational level to hold these community leaders accountable. So, were you working directly with municipal or city governments, or did you involve NGOs in that process? So that's one question. And to what extent did you involve the private sector in these subnational platforms? And what kind of resources that you sort of saw coming in were from those type of private sources? Over.
Thank you for those questions. So I see there's a lot of interest around the community accountability of leaders. The platform that is created at the local government level has the local government as the fulcrum. So they coordinate the activities to move this momentum forward. And we have noticed that the public sector really delivers just a small percentage of the services and the momentum, and that it's important that the platform brings on the private sector and the community and other stakeholders. And so we're coaching the local government to be the fulcrum for this and to manage and coordinate these partners. Specifically with the private sector, historically, the government hasn't known how to work with the private sector and to harness their strength. And we're coaching and teaching them how to do that. An example is in Kenya, and the government now working very closely with the pharmaceutical association, such that they are now partners, and they sit in the program implementation teams meetings at the local government on a monthly basis. Regarding the community being involved, in places like Nigeria, Nigeria has the advocacy core group, which consists of several players in the community, religious leaders, the media, etc. And they are the mouthpiece of the community. And this advocacy core group has been empowered to sit at table with government and advocate. So that is a way by which the community also comes into this. I like to say that civil society has also not necessarily been engaging, for example, with the assemblies at the local level. So part of what we're doing is working with the government, empowering the government to empower civil society organizations. So they are not knocking their heads together, but they are working together to be able to reach the assembly to help create line items for family planning, ring fence them, put resources in there. And so that's just a nutshell of how this operation is happening. It's a platform where we're looking at all those players coming in there, but then being driven by the local government. And the leaders that we're talking about, we talk about political leaders. So it's about influencing the political leaders to put their money where their mouth is.
Thank you. Very quickly, if we could have the very final question to Martin, because I know that this is on a lot of people's minds. Co-financing for family planning commodities. We've heard the Gavi example. We, of course, know the Global Fund examples. Could you quickly speak to whether this can work for family planning, or do we expect some barriers in this space? Over.
Thanks, Arun. So, I mean, I think this is an example of a critical catalytic investment that we need to make. It's certainly a big part of the discussion for the next 10 years. We see this as a highly effective approach. Critically, of course, it involves the sort of monetization within the government's own health accounts of commodities that they may have been seeing as free or somewhat external to their finances, in then having a domestic government co-finance a proportion of those commodities. It obviously ensures high quality and lower prices. It will then hopefully involve then an evolution, a compact, which will show an increased amount of co-financing over time. There are challenges, of course, but in the service of ensuring that there is that broad method mix in countries, that there is that availability of a critical set of self-care methods, which are of course of ever increased importance in the current landscape, and of course towards our stated aim within universal access of responding to the needs of women and adolescent girls, of men and of families in providing that broad range of methods. It's an approach that we need to undertake, but will require a lot of clear conversation, negotiation with each of the countries that will be committing themselves to our family planning partnership over the next 10 years. Back to you, Arun.
Thank you so much to Martin. We're almost at the end, and I know that we could not take up all of your questions. There's some very thoughtful questions and also some follow-ups to what the speakers have presented. I request you to take a look at the link which has been posted in the chat to the Family Planning Financing Roadmap website, which is initially funded by USAID and was started by HP+, and we will be happy to take on your questions and to get responses from the presenters as part of the community of practice. So thank you very much for attending today's webinar, and thank you to the presenters and speakers for their presentations today. Please have a good day, and hope to speak to you on the community of practice. Over. Thank you.